بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته، والصلاة والسلام على سيدنا وحبيبنا ومعلمنا وقدوتنا محمد صلى الله عليه وسلم. السلام عليكم جميعا، واسفين على الإطالة لظروف العمل الفترة الماضية. اليوم إن شاء الله نتكلم عن interesting case I already find last week in our transplant rotation. PTLD is post-transplant lymphoproliferative disorders. I hope everyone will get benefit today from this presentation. I will concentrate only to the clinical point for this topic today. I have many slides and many information, just I will go to the clinical point. I will try to finish in summary, and I will go to the clinical point only. I will not go to more details. الموضوع ده بالعربي يعني ازاي تكتشف ان في المريض بتاعك بعد ما خد الترانسبلانت، بعد ما زرع الكلى وكده، زي الاميونو سبريشن او الكومبليكيشن بتاع الترانسبلانت اميونو سبريشن از سايد افكت من العيان ده، تكتشف انه عنده اورام لا قدر الله بعد كعرض جانبي للادويه المناعه المثبطه الادويه المثبطه المناعه لزراعه الكلى. اولا بسم الله الرحمن الرحيم. قالوا سبحانك لا علم لنا الا ما علمتنا انك انت العليم الحكيم. صدق الله العظيم. بسم الله الرحمن الرحيم. وقل اعملوا فسيرى الله عملكم ورسوله والمؤمنون. صدق الله العظيم. بسم الله الرحمن الرحيم. إن الله وملائكته يصلون على النبي يا أيها الذين آمنوا صلوا عليه وسلموا تسليما. اللهم صل وسلم وبارك على سيدنا محمد. First slide, I like this slide. If you not understand or you not read before for this disease, how you can improve your management for your patient. You can't improve what you don't understand. You should understand as you can, at least to start better or initiate better approach to manage your patient, and will end by the best outcome for your patient. Today we'll discuss this disease, post-transplant lymphoproliferative disorders. I know it's a difficult topic and a hard topic, and not rare, but you should think in this disease in patient with kidney transplant. After the end of this session today, you will know and you will not forget to put him as a differential diagnosis for many symptoms or signs that came to you in your clinic or in emerge or in consult for any transplant patient. Our objective will start as usual by case presentation and just some hint summary, small hint for EBV virus, the epidemiology of this PTLD disease, and review data regarding the incidence and the risk factor for development of PTLD and pathogenesis of this disease, and the classification according to WHO last classification, diagnosis and management, discuss the possible strategies to reduce the risk of PTLD, review the current recommendation regarding management of PTLD and the future scenarios. We'll start by the case number one. We have 39 years patient with living donor kidney transplant with ABO incompatible. This living donor, this is a male patient with living donor with ABO incompatible. This transplant done already 2012. Primary kidney disease, granulomatous polyangiitis, this ANCA vasculitis, and the patient past medical history, this ANCA vasculitis at age of 12, and already this came by glomerulonephritis signs and symptoms, and with pulmonary hemorrhage, arthritis, mesenteric vasculitis, and esophagitis, and subtotal parathyroidectomy in 2010, and already this patient with antibody-mediated rejection, T-cell mediated rejection as a past medical history for him after kidney transplant, and right orchidectomy already done 2013, and the EBV status for him, donor is positive and the recipient positive. Both is positive. Past immunosuppression, steroids. Just to summarize, don't forget this summary for this patient. 39 is young, living donor, incompatible. The primary disease ANCA vasculitis, and this patient ANCA vasculitis, I'm sure he received many immunosuppression during his treatment of his GM before, and this patient also after kidney transplant complicated by antibody and T-cell mediated rejection and received heavy immunosuppression. This is the all death risk factor for development of our disease PTLD, and the EBV virus status positive for both donor and the recipient. Past immunosuppression he received before for this GN disease and arthritis, received this steroids, methotrexate, cyclophosphamide, azathioprine, and rituximab. ABO-compatible transplant, he received before transplant IVIG for doses, plaques, and rituximab as a desensitization protocol. And in December 2012, early rejection treated already complicated by antibody and the T-cell mediated rejection treated by IVIG, plaques, and thymoglobulin at that time. Clinical presentation 1 month ago, presented by fatigue and poor appetite. Fatigue, poor appetite, headache, constipation, itching, no respiratory symptoms, fever, night sweat, or weight loss, or palpitation, seizure, vomiting, reduced urine output, no joint symptoms, visual symptoms, palm pain, psychiatric symptoms. Transplant medication is intact, 7 milligram, bread 5 milligram of my Fortix since 2018 because leukopenia. This patient complicated by leukopenia and thrombocytopenia. At that time, we decided to hold his myfortic and keep only tacrolimus and the prednisone. And he's on vitamin D as a prophylaxis for osteoporosis for this prednisone or steroid side effect for the last many years. Clinical examination is fully conscious. CNS examination, no phoconeurological deficit. Otherwise, his examination is normal. Vital sign is stable, afebrile. And head and neck, no palpable lymphadenopathy and no congested veins. Chest is clear, cardiovascular is okay, abdomen soft, non-tender. Bowel sound was audible, no organomegaly, no otitis, lower limb no edema. With regard to his lab, blood sugar is okay. I think it's 4, 5 millimoles, 7 millimoles. That's okay. Bicarb is a little bit hypo, a little bit acidotic. Sodium is okay, and potassium is okay, and chloride is okay. Urea, 26, it's 35, 30. This is the last one here. Last one, 10 September 20 from September 19 to September 20. On September 20, he came by creatinine. How much? Creatinine came 269 from 300 from 279. This December 2019 and this September 20. I think it's around his baseline, but already it's CKD already. And also with hypercalcemia at that time, and magnesium is a little bit low, and phosphorus is normal. Other liver function test is normal, and the little bit leukopenia and anemia, thrombocytopenia here already. So my fortic can hold for this region, this hemoglobin, this white blood cells, and this platelet with this pancytopenia for our patient. Because this hypercalcemia, we ask for serum protein electrophoresis. Urine protein electrophoresis does diffuse gamma region, and negative for urine protein electrophoresis, and protein PCR creatinine ratio just 0.1 gram per liter. ABV PCR 3,200, I think 3 logs, elevated already. And BTH5 is a little bit low. Vitamin D is 97, 125 hydroxy vitamin D 257. All this the workup for hypercalcemia. Inca is negative. Thoracic echo already no pericardial effusion, no wall motion abnormalities, normal left ventricular and right ventricular function. Okay. Investigation ultrasound graft already requested as a routine workup for this patient is normal. We request CT for him, abdomen and pelvis, and this there is 9 or around 10 centimeter lobulated heterogeneous solid mass centered in segment 8 of his liver, slightly hypoattenuated area in the central portion of the mass, likely necrosis. And this already we taken needle aspiration biopsy for that, post-transplant lymphoproliferative disorders, monomorphic type. This PTLD already and monomorphic type. This is a Boris type, and diffuse large beta cell lymphoma, germinal center B cell-like phenotypes, and Epstein-Barr ER negative already for this patient. This scan, we decided to do a scan screening for him. We found metabolic active right loop hepatic mass consists of histologically conformed PTLD and diffuse large beta cell lymphoma, and diffuse small metabolic active mesenteric nodes in the lower abdomen and pelvis. Suspicion for further involved nodes, no supradiaphragmatic sites of nodal or other extranodal finding, of disease identified. Immunostaining for this, our biopsy shows that the neoplastic cells are positive for CD10 and CD20, CD30 also, and this other finding, and are negative for CD3, 5, and others. Normocellular bone marrow aspiration done at that time, and this normocellular bone marrow, there is no evidence of lymphoproliferative disorders when we consulted hematology. You know, when you discover or you think or you found this match or lymphoproliferative or PTLD, you should consult the hematology, and the hematology will come to do his workup for, especially patient with pancytopenia like our patient. You should involve the hematology direct from the first biopsy report. Management hypercalcemia. What is the management of hypercalcemia? I have one case for hypercalcemia I will present soon. Hypercalcemia, to diagnose, to manage any patient with hypercalcemia, you just start to pull your patient by IV fluid, especially normal saline. And after that, if the patient pulmonary edema or volume overload, you can give Lasix. And then we can give bamidronate and calcitonine as our patient here. This patient already returned to the emergency after 2 days of discharge. We found his calcium reading again is high, and started prednisone 100 milligram, which control his hypercalcemia, and the prednisone another line of treatment, especially in your transplant patient. Especially with this patient with pancytopenia, also will help all together. Immunosuppression, prednisone 5 milligram daily, reduce the graph. Just prednisone now, current immunosuppression, last immunosuppression 5 milligram, prednisone, advagraph 3.5, decrease 50% when we discover this query PTLD. Our plan with the hematology, reshop chemotherapy with plan for 3 week cycle for 6 cycles. With plan from hematology to cut down MMF already in hold since a long time, and cut prednisone 5 and advagraph 3.5 to keep it target around 3 to 4 or 5 maximum, and restart reshop chemotherapy with plan 3 week cycle for 6 cycle. This number 2 is a 48 years old male, 1 week history of right buttock and radicular leg pains with palpable lump in his right buttock. We have this swelling or mass in his right buttock with constipation and no other constitutional, no other symptoms like fever, weight loss, night sweat like that. CT abdomen already done, direct with contrast. If you found this patient with transplant with this mass, you should do CT with contrast. Show this pre-sacral mass with query PTLD, some retroperitoneal also lymph nodes discovered or observed during CT abdomen with contrast. The past medical history for our patient, his DCD donor after cardiac death, already renal transplant 2014. He received his kidney transplant 2014, and we saw him in 2015. And he had other past medical history, systemic lupus, and he received cyclophosphamide and immunosteroid for that disease before at the age of 15. And he received this 23 years lupus nephritis already before, and his end-stage renal disease and dialysis this period, and he transplanted in 2014, and his donor positive for EBV, and the recipient already negative. The second case. And pathology, we decide to take biopsy from this mass, this sacral mass already, and this retroperitoneal lymph node. Just we take from this right iliac fossa or right buttock sacral mass already. We take in this biopsy. Biopsy pathology came by monomorphic PTLD, post-transplant lymphoproliferative disease with CD20 positive Burkitt lymphoma. By immunophenotype cell where CD5 negative, CD10 positive, CD20, and B-cell lymphoma 6 positive, and other positive. Scan done on September 2nd, extensive bulky metabolic active soft tissue mass in the pelvis. Extensive bulky metabolic active soft tissue mass in the pelvis. invading the acidic notch, the thyroid notch, and likely infiltrating the patient bone. Lymphadenopathy in the retroperitoneum, also mesentery and small volume nodes above the diagram, multifocal abnormal this mass uptake in the skeleton in keeping with the small volume osseous involvement. Bone marrow, because I told you before, any patient who is diagnosed with PTLD, he should consult. You should refer direct to hematology to help in your management. Just one moment. Bone marrow already there is no immunophenotype evidence of for monotypic B-cell population, and we already CSF is normal at that time also. After biopsy is shown this stage 4A, this Burkitt's lymphoma, and he started re-echoduct regime by hematology or oncology at that time, cyclophosphamide, vincristine, and doxorubicin, and methotrexate, and leucovorin. Allopurinol, we are giving 100 daily for tumor lysis syndrome, and a complication later for this patient. Everolimus discontinues, continue just only in prednisone, 5 milligram oral daily. This is summary for two cases to start our talk for our disease today, PTLD. Just I'll give you a small hint also rapidly for post-transplant malignancy. Malignancy is the second commonest cause of death in renal transplant recipient after cardiovascular death. You know what is the most common cause of graft loss? The most common cause of graft loss, this with functional graft. What is the most common cause of death? Cardiovascular, followed by malignancy, then infectious. Most common malignancy, non-melanoma skin cancer. The most common is post-transplant malignancy, affecting 2 to 10% each year. Transplant recipient 2 to 3-fold increase than general population and the complicated malignancy after kidney transplant. 2 to 3-fold increase in comparison by general population. What is the etiology? What is the cause of malignancy after kidney transplant? What do you think? Number one, post-transplant immunosuppression. Immunosuppression is number one the cause of malignancy post-transplant. Immunosuppression reduces the host immune response to viral infected cells, malignant transformation. Immunosuppression also decreases tumor surveillance by immune system. Immunosuppression decreases the host immune response to viral infected cells, malignant transformation. This is linked by malignant transformation. Immunosuppression decreases tumor surveillance by immune system. Direct oncogenic effect of immunosuppression drugs like azacitidine did DNA damage. Cyclosporin increases transforming growth factor beta, promote tumor growth factor. Increase TGF-beta, the cyclosporin, azacitidine, urine inhibitors, DNA damage. Previous immunosuppression like cyclophosphamide increase lymphoma and urothelial, increase risk of lymphoma and urothelial cancer. What is the aim of end-stage renal disease? What do you think? Uremia, decrease the clearance of oncogenic toxins. This is the commonest cause. You should think why malignancy common post-kidney transplant. One rule for immunosuppression, decrease the host immune response to virally infected cells, lead to malignant transformation. Immunosuppression can decrease tumor surveillance by immune system. Direct oncogenic effect of immunosuppression like azacitidine, DNA damage, cyclosporin increase transforming growth factor beta, promote tumor growth. Previous immunosuppression like cyclophosphamide increase lymphoma and urothelial cancer. This stage renal disease lead in the uremia, decrease clearance of oncogenic toxins. This from Oxford of kidney transplant. 11 shows the relative risk is those cancer over represented in transplant recipient. This regard cancer over represented transplant recipient, this malignancy type, and this relative risk compared to general population and this associated virus. Kaposi sarcoma, don't forget H, human herpes virus 8. More 100 risk, relative risk increase with comparison with general population and melanoma skin cancer in 200. This sometimes come at the MCQ and the MRCP and nephrology subspecialty exam. UK. Don't forget this number. This is Kaposi sarcoma more than 100. Relative risk increase in comparison with general population, and the virus already HHV 8. Non-melanoma skin cancer 10 to 200 relative risk in comparison by general population. This human papilloma virus. Lymphoma including PTLD is more than or around 10 relative risk increase by general population, and the EBV virus, and the other, I think, human papilloma virus, or this other lips or oral cavity, vulva, and penis and anus, liver, all this liver hepatitis B and hepatitis C, that's around 10 to 5. Okay. Not go more in deep for that. Post-transplant lymphoproliferative disorder disease, the most common malignancy diagnosed in pediatric transplant recipients, especially in pediatric. And the cause in pediatric because the adult already taken immunity, most of adults around 30 to 40 taken around 80 to 90% infected by this virus, EBV virus, Epstein-Barr virus, and already have immunity for that, and they have IgG positive, most of adult patients. So the most common malignancy diagnosed in pediatric transplant recipient, and the second most common in adult. PTLD refer to a wide spectrum of disorders from an infectious mononucleosis like illness to disseminated and sometimes rapidly fatal malignant lymphoma. 50% of all PTLD cases are diagnosed within 1 year of transplantation, around 50% within 1 year from kidney transplant. Remaining 50% are distributed in, through as the lifetime of the graft. Around 50% of PTLD should be diagnosed within 1 year, and the other 50 in the other years. Here, incidence of PTLD in adult pediatric transplant will go to adult direct. Our kidney around 1 to 2%, kidney 1 to 2%. The most common small intestine and lung, heart is most common, and heart, lung, intestine more than kidney. Just 1 to 2%. PTLD is one of the most feared complications following kidney transplant. Over a 10-year period, the risk of PTLD in kidney transplant recipient is 12-fold higher than non-transplant population. With the risk over 10 years period, the risk of post-transplant lymphoproliferative disease 12-fold higher than a non-transplanted population. PTLD is a wide spectrum disease and presentation, EBV virus positive or negative, benign lymphoproliferative or infectious mononucleosis, infectious mononucleosis like syndrome, through malignancy, localized or disseminated, nodal or extranodal. Clinical presentation vary from slowly progressive to permanent reduction or withdrawal complication. We'll see. What is the definition of our PTLD? Proliferation of lymphoid or plasmacytoid cell lines. And just to summarize the definition, and we'll go to details now. The proliferation of lymphoid or plasmacytoid cell lines in an immunocompromised patient in solid organ transplant or bone marrow transplant. EBV associated frequent but not mandatory. EBV associated especially if donor positive and recipient negative. The proliferation of lymphoid or plasmacytoid cell lines. We'll give a hint for an EBV virus. EBV virus is a gamma herbivirus found in latency in the cells. They will come in details for that. Very successful pathogen can cause the disease in the immunocompromised as well as the immunocompetent milieu, and we'll come to that also. EBV is a, just don't forget, I will not go most of the details, but don't forget EBV is a genome of linear DNA virus already molecule that includes approximately 100 viral proteins that are expressed during replication. Latency of our beta cells, virus already when infected basis will go to latency in beta lymphocyte and the chronic replication in the cells of the oropharynx, and we'll come to that. Cell transformation is associated with T cell activation, continuous proliferation, immunocompetent proliferation of the transformed B cell usually is controlled by cytotoxic T cells. This is not the case with immunosuppressed. And we'll come to this by picture now to be easy for you. Just don't forget this is a component of EBV virus. composition. This is a glycoprotein. This is an influence for the virus. This nucleocapsid for the species viral and viral genomes already here. This is a viral genome, and this document this is a collagen around this nucleocapsid and this viral genome already. And this multiple loci here and the genomes for the virus. And this viral genome around 172 kb DNA already for Epstein-Barr virus. And here, a herpes virus transmitted through saliva. The main, what is the rule, the mode of transmission of our herpes virus? Herpes virus transmitted EBV virus or herpes virus in general transmitted via saliva. More than 90% have immunity to EBV virus by age of 40. I told you, so the child more common to this malignancy, to this disease than the adult, because by age of 40, around more than 90% have immunity for Epstein-Barr virus. Acquired in early childhood or adolescent, usually subclinical, 50% infectious mononucleosis. Infection through the blood transfusion is rare. Leukodepletion. The patient leukodepleted already. The proteotypes transforming virus, Burkitt's lymphoma, Hodgkin, non-Hodgkin lymphoma, nasopharyngeal carcinoma, leiomyosarcoma, and PTLD. And we'll come here. Primary infection and the persistence infection in details. You will come to saliva. This is the source of this virus, Epstein-Barr virus. To oropharynx, you will find this epithelium of the mucous membrane and lymph nodes, and this epithelium will go to, this virus will go to rest in this naive B cells, and through the lymphoid tissue and the peripheral blood. And the athletic Epstein-Barr virus infected cells will be infected by this virus, and this will end by infected EBV virus infected beta cells. This will be suppressed or inhibited by this cytotoxic and the natural killer cells. This is a normal one. It is a normal person. But if a patient immunosuppressed and this cytotoxic and depleted by patient receives immunoglobulin or immunosuppression, this will not be inactive, but will be activated and proliferating and lead to lymphoid proliferation and our disease PTLD already. And this, this latent infected resting memory cells already here. With the reactivation of these cells, with the immunosuppression, this leads to ABV infected lytic and more resistance infection by this ABV virus. And we'll come to pathophysiology of and the treatment of strategy. Just to summarize the pathophysiology and treatment strategy for PTLD, ABV virus, when he enters the body through the mucous epithelium like this, ABV virus, when he enters the mucous epithelium of the laryngopharynx and infects the submucosa cell, infects these submucosa cells here. Again, here the beta cells and beta cell PTLD apical transformation and the PTLD treatment. We'll see now this, and this will be transformed to that. When the Epstein-Barr virus already entered the body through the mucosal epithelium or the oropharynx and infected the submucosal beta cell, resulted in viral gene transcription here inside the beta cells, and then also germinal cells expression during the germinal cell reaction. Some latent infected memory cells leave the germinal center and persist in immunocompetent individual. EBV infected beta cells are recognized by host CD4 and the CD8. CD4 thanks for CD4, CD8. This catch infected beta cells, beta cells already, latent beta cell. And natural killer cell also expressing this infected beta cells, also eliminate the virus infected. This all CD4, CD8, and the natural killer cells, all that participate in elimination of this viral infected beta cell. PTLD prevention can consist of administration of antiviral. We'll come to that point later. Antiviral and EBV specific T cells. Immunosuppression agent impede the EBV direct immune reactivity and are important risk factor for development EBV positive PTLD. We'll come to that point. And that's to know to be easy for you. We'll come to this diagram. EBV here at the primary infection. I know it's difficult explanation, and I will try to simplify here. We have the primary infection as we mentioned here. The primary this EBV virus will infect this epithelial cells, and will stay in these cells. Will be react with this naive beta cells. This will end by EBV infected beta cells latent will become latent cell because this activity of our T cell, cytotoxic T cell and natural T cells for our body in our body. Primary infection, just I need you to concentrate here. Primary infection will come. This EBV virus invades the epithelium of or laryngeal or oropharynx, and they will catch it to our beta cells, the naive beta cells in submucosal surface. This is a primary infection now. This virus here, this EBV and these beta cells will be inhibited or controlled by this, T cells and natural killer cells, okay? And to prevent this replication and polyclonal proliferation, if the patient receives immunosuppression, this will end by proliferation and early lesion, polymorphic lesion, and monomorphic lesion, from replication to polyclonal lymphoid aggregation, polyclonal mini shapes here, and clonal expansion will be ended by this monomorphic PTLD. We have this time the replication, polyclonal lymphoid aggregation, this early lesion, polyclonal expansion, polymorphic PTLD, monomorphic this in patient under immunosuppression. Again, we have the source for EBV virus either from primary infection from the mucosa or latent infection in our patient before, as our diagram before, or either from graft from a donor. He will give you the kidney with EBV virus if it's donor positive, and this from primary infection. Our CD4, CD8, and the natural killer cells, CD4, CD8 natural killer cell, will keep latency for this infected naive beta cells. But after the patient, this easy diagram for you. After the patient receives immunosuppression, it will be reactivated, proliferative, and will end by early lesion, and then polymorphic, and this monomorphic lesion if the patient continue heavy immunosuppression. And this is a mechanism for Burkitt lymphoma and Hodgkin lymphoma, and this PTLD already. By this EBV virus will attach to the mucosal surface, the latent cell, naive beta cells, and proliferation differentiation for each one, and different programs already to be. I will not go to more details for that. And this summarize just an infection to epithelium EBV virus attached to our oral mucosa or saliva, from saliva to oral mucosa to the submucosal naive beta cells. Naive beta cells, if any problem in naive beta cells here, if will end by immunoblastic PTLD, and this naive beta cells should be go to germinal centers. If any problem in germinal cells, this will end by Hodgkin lymphoma. And after germinal centers, dividing in memory beta cells, if any problem here also, especially Epstein-Barr virus in A1 only, it will end by Burkitt's lymphoma. Maybe the thing is okay, just will go by resting memory beta cells. This is a latency. This will be a memory cell if in patient immunosuppressed or he received antigen, and this memory cells knows this antigen and react with this antigen. And just to remind you, this is our source from saliva to submucosal adenoid, tubal tonsils, palatine tonsil, lingual tonsils, and they will get germinal center from the epithelium. And this will end by this latency of beta cells already, or memory cells. Other clarification for Epstein-Barr virus will attach by epithelial cell and will end by naive beta cells. Again, this Epstein-Barr virus to naive beta cells gross germinal center here. Gross programs already will happen for this naive beta cells. and this will end by latency program. This latency already program here. This is a latency program, and our default program, this latency program here, and this viral replication. I think that this latency beta cells, already memory cells, when we reactivate it here, will be and the viral replication under immunosuppression will end by proliferation and differentiation. Again, just to remind you, from saliva, antigen submucous saliva, surface epithelium, antigen will invade that, and this will join by naive beta cells, will end by activated this lymphoblast, and it will enter germinal center in the lymph nodes and mucosa, and this program cell activation here will be having antigen plus T cell helper. Will end, all this will end by memory cells and cell division. Memory cells or latency time bar NE1 only. This will end by latency. When any patient under immunosuppression or like that will end by infection and amplification, proliferation, and this will end by our disease PTLD. Again here, naive beta cells and germinal center and latency cells and memory cells. When under immunosuppression, this proliferation, this activation, and lead to more proliferation of our naive or memory beta cells. Here, just to summarize for you, neutralizing antibody infectious virus, Epstein-Barr virus, viral replication, or a new infection growth program, differentiation, peripheral pool, latency program, all this will be inhibited by cytotoxic T cells. Otherwise, if the patient immunosuppressed will end by proliferation and our disease. In serology, just for this incubation period and active period and this chronic or recovery period, acute phase, incubation period is weeks, will take weeks to be having, acute phase from week to months, and after that recovery phase after a few months. Just in acute phase, you can find all this immunoglobulin G, and most common this immunoglobulin M, and after months, just you'll find all this patient already immune by immunoglobulin G. As we mentioned, definitions is proliferation of lymphoid or plasma cells, immunocompromised patient after solid organ transplant or bone marrow transplant. EBV virus association frequent but not mandatory. PTLD is our lymphoma that occurs after transplant, cell proliferation due to planted immunological surveillance, risk immunosuppression, EBV virus, all this risk immunosuppression or infection by EBV virus, Epstein-Barr virus, post-transplant reactivation, primary EBV infection through the donated organ or via environmental exposure, as we discussed before. 21% of all cancers in a recipient with solid organ transplant are compared with 4 to 5% immune competent. Large registry and single center study in the past 10 to 15 years showed increased incidence and significant morbidity and mortality. And this will increase morbidity and mortality with this disease also. And then by model curve for incidence, initial spike or initial peak or the late spike. Most commonly Epstein-Barr virus positive during the first year, especially if you receive donor positive to recipient negative, you will see during the first year. As I mentioned before, during the first year, you should exclude 50% of your patients with this disease, and the remaining years, another 50%. Late spike, mostly Epstein-Barr virus negative, typically occurs 5 to 15 years after transplant. This is late spike, mostly with EBV Epstein-Barr virus negative for this patient within 5 to 15 years after transplant. Induction therapy major role in early PTLD transplant lymphoproliferative disease were late cumulative immunosuppression. Induction therapy, we saw this already mainly with more commonly with ATG or thymoglobulin. PTLD already a high incidence of extranodal involvement. The two most important etiological factors for this PTLD infections with Epstein-Barr virus or immunosuppression, either infection by this virus or immunosuppression, heat immunosuppression, immunocompetent individual Epstein-Barr virus exposure lead to latent EBV virus infection or of beta lymphocyte. Both antibody and cell-mediated immune response prevent proliferation of EBV virus-infected cell and likely eliminate the cells that have embryonic malignant transformation. This patient who is immunocompetent. Immunosuppression following transplantation suppresses both of this function of the recipient immune system. This is a mechanism we discussed before. If the patient immunocompetent will prevent this malignant transformation of the lymphocyte infected by this virus. After immunosuppression following transplant suppresses both of this function of the recipient immune system. What is the risk factor? Primary EBV Epstein-Barr virus infection in EBV-naive recipient, usually children. EBV-naive recipient receiving a transplant from donor positive for Epstein-Barr virus. Immunosuppressive regime, especially T-cell depleting, especially thymoglobulin. We are common. Okay, T3 already not common use, but we are using thymoglobulin. This is a common. Will end by this and another maintenance also heavy maintenance of immunosuppression also will end by this risk factor for our disease PTLD. Transplant type immunosuppression like lung more than kidney and liver, and this according to transplant type lymphoid tissue mass intestine more than lungs, and the least one is kidney and the commonest one is intestine for this disease EBV. PTLD. CMV disease also as a risk factor, absence of prophylaxis acyclovir or ganciclovir. Primary EBV infection and EBV naive recipient in an EBV naive recipient. If the patient receive infection after transplant, or the patient receive donor with positive Epstein-Barr virus, immunosuppression patient will receive an ATG or heavy maintenance immunosuppression. Transplant type lung more than intestine, more than lung, more than liver, more than kidney. CMV disease absence prophylaxis during a transplant, especially patient receive immunosuppression. And here a risk factor, as we mentioned, early PTLD occurring is the first transplant. This according to age, elderly more than, I think some problem here. Type of organ transplant, intestine as we mentioned before, more than kidneys. And primary EBV infection after transplant, young recipient age or older age, EBV infection, hepatitis C virus, thymoglobulin also as induction. Recipient demographic, as regard race or gender, no significant bias or data for that. Just the young recipient age is an important risk factor because the patient, if you have young patient, still this patient not get infection and not get immunity like an adult one. All the recipient age is also risk factor, likely due to a ascendant immune system. With the older age, already high risk for this. Also as a risk factor, induction therapy, as we mentioned, ATG. I will go rapidly because I have many slides. And no difference between the maintenance therapy between cyclo and the TAC. MMF not associated with increased risk also. Risk of factor for, as we mentioned, type of transplant, EBV virus serostatus, especially if a donor positive and recipient negative, and this intestine more than kidney, more than others. Kidney is the lowest one, test is the highest one, this type of transplant. Donor positive, recipient negative, immunosuppression, ATG induction versus Frederick's ATG is more risk. Host factor also, age like that. Young or elderly. Incidence post-transplant disorders in various transplant. This is bone, hematopoietic stem cell transplant already here is the highest incidence, a maximum one, and the lowest one followed by multi-organ test, lung, heart, liver, pancreas. The lowest one, that's 2.5%. This is the kidney from 21% for bone marrow transplant. This is the highest one for EBV, Epstein-Barr virus, PTLD disease. And this also, as we mentioned before, relative risk of non-Hodgkin lymphoma, heart and the lung more than kidneys. The heart, lung, liver, pancreas, the lowest one is kidney here, and the risk, important risk factor for this. And this just to summarize the risk factor after solid transplant. Establish risk factor, zero strong evidence of risk, weak evidence of risk. Type of transplant organ, just as we mentioned before, intestine more than the kidney. EBV mismatch, especially recipient negative and donor positive. the most established risk factor according to type of transplanted and the EBV mismatch. Strong evidence risk, increased risk associated with ATG induction, and as regard the maintenance, no significant difference of that, no increased risk associated with MMF or basiliximab or teclistamab. Weak evidence underlying hepatitis C and other race like that, weak risk factor for this disease. And we mentioned the location already, maximum and minimum. Lymph nodes, the most common site for this EBV virus, PTLD. PTLD is common on lymph nodes, followed by GIT, followed by urinary or general nervous system, and the liver and the lungs. Already this lymph node is common here, the most common site, followed by GIT. Urinary system is lowest, and liver and the lung. This the most common site here is lymph nodes, is a common site, followed by GIT. What is the incidence? Already, as we mentioned, EBV negative, EBV positive is higher incidence with the EBV according to B transplant based on the incidence of non-Hodgkin lymphoma in this disease based on the pre-transplant EBV virus, Epstein-Barr virus serostatus. If EBV negative is higher incidence of non-Hodgkin lymphoma. As I mentioned here, organs, pediatric adult will go to all organs and adult direct because we are adult nephrology. Just as the highest incidence of post-transplant lymphoproliferative disease in kidneys, comparison bile intestine, and heart, lung, liver, pancreas. Lowest one, 1 to 2% only kidney, 5 to 9, I think to reach to 10% in all other organs. In comparison, bile kidney, 1 to 2% only. This incidence, as we mentioned before, the bone marrow transplant is the highest incidence of for PTLD in comparison bile kidneys, 2.5% from 21% in bone marrow transplant. And long-term infectious complication after transplant. That's the diagram. I found this picture is nice for us. Early post-transplant infection around the first months after transplant, nosocomial infection during the hospitalization, multi-drug resistance organism, MRCA, VRE, and the ESLP and the CRE. And Clostridium difficile colitis, surgical sites, the most common, urinary tract infection, castor-related bloodstream infection, pneumonia, donor-derived infection, atypical post-transplant course, and recipient-derived infection include colonization, influenza, Pseudomonas aspergillosis. The first common infectious first months after transplant, from 1 month to 365 days after transplant. These are polyomavirus, BK virus, hepatitis C, Cryptococcus neoformans, Mycobacterium tuberculosis, strongyloids, Leishmania, PTLD, and after prophylaxis stop, pneumocystitis, ممكن BGB pneumonia, herpes virus, CMV, herpes simplex virus, varicella zoster virus, hepatitis B virus, listeria, pneumocardia, toxoplasma community acquired infection, direct infection, pneumonia, Clostridium difficile, or this from 1 month to 1 year. More than 1 year of opportunistic infection. When this occurs, must consider why they happen late, CMV and BGB, and PTLD, Epstein-Barr virus, nocardia, community-acquired infection, Western Nile virus, community-acquired pneumonia, redirect infection, influenza, aspergillus, and hepatitis B and C. Incidence, risk factor, clinical management, with cohort outcome, PTLD, disorders, kidney transplant recipient. That already a cohort study from 2039 patient with different EBV mismatch already, and distributed, and the incidence around 0.1 cases per 100 person per year. 0.1 cases per 100 person per year. And the recipient negative or at high risk for developing PTLDs and recipient positive by high hazard ratio 7.52. And clinical manifestation, when the patient came to emerge or consult or in clinic, you should palpate for any lymph nodes. Please don't forget the lymph node examination, cervical and axillary and buttocks, bilateral inguinal areas. Just any fever, and patient came by fever, you should check this size of our lymph nodes. And weight loss, if you found your patient weight loss, patient is weight 60 and now 50, 40, like that, with night sweat. Like tuberculosis, TB pictures, lymph nodes, fever, weight loss, night sweating, like that. A clinical presentation, PTLD present with localized or disseminated disease, often aggressive, rapidly progressive, and potentially life-threatening. Clinical presentation is variable, either from fever, as we mentioned, 57% of patient, and lymphadenopathy, lymph node, large lymph node, 38%, gastrointestinal symptoms, obstruction, 27%, infectious mononucleosis likes, fulminant, 19%, pulmonary symptoms, and CNS symptoms, 13%, weight loss. Forget triage of fever, weight loss, night sweat, and lymph nodes. For this is the main, and also we can involve allograft tissue and can cause declining organ dysfunction, and this will appear with kidney biopsy tissue diagnosis. As I mentioned, fever, number one, lymphadenopathy, GIT symptoms, infectious mononucleosis-like symptoms, pulmonary symptoms, and urinary and weight loss already. As we mentioned, fever, night sweat, weight loss, fever, night sweat, weight loss, maybe both acute or severe. I repeat it to fix in your mind: fever, night sweat, weight loss, and lymphadenopathy. Transplant dysfunction, patient came by EKI, you should rule out PTLD. Don't forget PTLD. Just put in your differential diagnosis. Maybe this cause of EKI or rising creatinine or graft dysfunction. This PTLD, Epstein-Barr virus, is more likely to involve the transplanted organ and other solid organs. Other solid organs like small intestine, beware of perforation, lung, liver, and central nervous system. 60% of patients present with disease localized to single site, 25% have nodal disease only. Lymphoma in immunocompetent patient, usually nodal, and with lymphoid organ involvement. PTLD 60 to 90% extranodal. The diver of extranodal presentation: kidney 1 to 2 years, central nervous system 2 to 7 years, GI 6 to 10 years. To diverse extranodal presentation, we need 1 to 2 years for it at least. Because most of PTLD 60 to 90% extranodal already. By virus positive plus mucocutaneous ulcer children may be present with head and neck involvement. From that, if you have children with transplant. The black one, EBV, Epstein-Barr virus positive PTLD, this is a black one, and Epstein-Barr virus negative, this is a gray one. This for extra nodal localization. We think here nodal with common with EBV negative more than EBV positive PTLD, and here extra nodal is common with Epstein-Barr virus positive than negative. And that's the most I need for you. And this other comparison by CNS and abdominal organs, intestine, bone marrow, transplanted organ. Epstein-Barr virus common with transplanted organ with the positive EBV, Epstein-Barr virus positive more than a negative one. Other abnormalities in the lab, what you will find and explain the anemia, thrombocytopenia or leukopenia. Cytopenia and explain, and you should put in differential diagnosis. I have one patient with severe thrombocytopenia. Just I saw him last week with severe pancytopenia. His platelet around 13 to 15, and he just came by right lower enjoying just mass. And already this mass already taken for biopsy, and we'll see result, waiting for result for this man. And he's cachexia and weight loss and anorexia, all symptoms with him. Most of the symptoms that we found this mass in his inguinal lymph nodes. And just we're waiting for a biopsy report for this patient, and just seen by hematology and recommend to start in high dose steroid. And he was severe pancytopenia already. Elevated serum lactate dehydrogenase also is one of the criteria for the malignancy, and hypercalcemia other criteria for your diagnosis. Hyperuricemia for tumor lysis syndrome, monoclonal protein in serum and urine. What is the difference between early and late PTLD? Early poly-oligo-monoclonal, this early associated with EBV, Epstein-Barr virus will be positive here. With early poly-oligo-monoclonal, usually monoclonal. This late presentation came by monoclonal only, but this poly-oligo-monoclonal, this with EBV virus positive, 20 to 40% are EBV negative. Usually B cells more than 90%, mostly B cells 10 to 15%, T cells also. Mostly B cells, but 10 to 15% are T cells. Here, usually more than early B cells, but here also 10 to 15% will be T cells with B cells. Diffuse early will be diffuse node affected, nodal affected in more than 90% extra nodal. This with a late presentation. Frequent allograft involvement, least likely to involve a graft, well-recognized risk factor, poorly identified risk factor for late presentation. Frequent response to immunosuppression, early better will respond to just to decrease immunosuppression, least response to immunosuppression, very bad, monoclonal, not good. And better prognosis and here poor prognosis, especially if T cell lymphoma are multiple site. Don't forget this table for differential diagnosis between early and late PTLD. Early, either polyclonal or oligoclonal or monoclonal. Late will be usually monoclonal only. Early will be positive Epstein-Barr virus. Late will be negative Epstein-Barr virus, around 20 to 40%. Early only beta cells or more than 90% will be just beta cell. But late will be around 10 to 15 T cells and the other beta cell. Early will be diffuse nodal involvement, more than 90% extranodal with late. Frequent allograft involvement, less likely involve allograft. Will recognize risk factor, in poor to identify the risk factor with late. Frequent response to immunosuppression. If you decrease the immunosuppression with early PTLD will respond, but late will not respond, will be resistance with you. This need maybe aggressive rituximab or chemotherapy, as we'll see later. Better prognosis with early, late prognosis with late. As we mentioned here, this most common early PTLD will be positive. After involvement common than here, less extranodal, but here more extranodal, non-destructive, but here high incidence of late Hodgkin lymphoma, monoclonal. Less often monomorphic, but here mainly monomorphic types. I mentioned before, no need to repeat again. Early PTLD will occur less than 1 year, 1 to 2 years. Usually EBV, Epstein-Barr virus positive, the cell PTLD. Late PTLD more than 1 to 2 years. Usually Epstein-Barr virus negative. Late beta cell PTLD, NS PTLD, non-beta cell PTLD. Okay, maybe 10 to 15% T cell involvement for that. But if early, less than 1 to 2 years with EBV positive, mainly beta cells. Late, more than 1 to 2 years with EBV negative and non-beta cell involvement. Classification, this is for the classification. 85 or more than 90% will be beta cells, 15% around T cells. As we mentioned before, morphological is early lesion, polymorphic, monomorphic, and others. Early lesion is better and polymorphic is better because monomorphic is beta cells and the T cells. It's mainly beta cells. Beta cell hyperplasia, as we mentioned, polymorphic PTLD and the monomorphic PTLD. Polymorphic is the most common form of PTLD. Polymorphic, a typical lymphocyte with destruction of normal lymphoid architecture. Usually Epstein-Barr virus positive, usually occurs in first 3 years post-transplant. Monomorphic high-grade malignant lymphoma, often Epstein-Barr virus negative, essentially identical to malignant lymphoma in general population, often occurs several years following transplant. This late presentation and bad prognosis. This early with good prognosis. Just WHO, the last classification here, recent classification for WHO organization 2017, classification of PTLD. Non-destructive, polymorphic, monomorphic. Non-destructive is early lesion already. As I mentioned before, Epstein-Barr virus positive in 100% for that, and there was good prognosis, and mainly beta cells. And polymorphic also same, mainly beta cells, more than 90% Epstein-Barr virus positive. With the polymorphic types, we have this classification: non-destructive, early lesion, polymorphic lesion, monomorphic lesion. This is destructive one, CD20, CD. diffuse large beta cell lymphomas, and T cells here involved with ABV positive, negative, and with T cell involvement for that. And this another just clarification. PTLD, just a non-destructive lesion, either plasmacytic hyperplasia, infectious mononucleosis of florid follicular hyperplasia, and this polymorphic type also. This after the early lesion, non-destructive lesion early, plasmacytic hyperplasia, infectious mononucleosis, and the florid follicular hyperplasia. This early lesion with followed by polymorphic type or lesion, and late this monomorphic type beta cell neoplasm or T cell neoplasm, and the last type Hodgkin, classical Hodgkin lymphoma, PTLD. Non-destructive PTLD, proliferating cell don't disturb the architecture, classically present in lymph nodes and tonsils. Non-destructive type, either plasmacytic hyperplasia, infectious mononucleosis, PTLD, florid follicular hyperplasia. Monomorphic, the late presentation of prognosis destructive proliferating monomorphic cells, destruct the architecture of lymph nodes. The proliferating monomorphic lymphocytic cells fulfill the criteria for typical lymphoma seen in immune component host. Monomorphic types, just classify beta cell and T cell PTLD, either beta cell or T cell. T cell, as we mentioned, 10 to 15%. Beta cell, diffuse large beta cell lymphoma, Burkitt's lymphoma, plasma cell myeloma, plasmacytoma, and this T cell, peripheral T cell lymphoma, and hepatosplenic T cell lymphoma. This is the monomorphic types, either beta cell differentiation or T cell differentiation PTLD, beta cell diffuse large beta cell lymphoma, Burkitt's lymphoma, plasma cell myeloma, and the plasmacytoma. And the T cell PTLD, peripheral T cell lymphoma or hepatosplenic T cell lymphoma. And if to summarize, either PTLD came by early lesion, immunosuppression reductions, that's good, and surgery if possible, plus or minus surgery. And if the patient came by polymorphic variant, this is immunosuppression reduction with rituximab, either with or without rituximab, with or without surgery at the end. Monomorphic variant immunosuppression reduction with rituximab. If CD20 positive, we'll give rituximab. If negative, we just will go to surgery after immunosuppression here. Here, monomorphic variant immunosuppression reduction, CD20 positive or negative. CD20 positive will give rituximab plus chemotherapy. If CD20 negative, will give just only chemotherapy. Just this classification or summarize the management of PTLD, post-kidney transplant, post-transplant, lymphoproliferative disease, by early lesion, immunosuppression reduction just only enough, or if no response, plus or minus surgery, polymorphic lesion or types or variant, immunosuppression reduction, and do CD20. If positive, I will give rituximab, and then plus or minus surgery. If negative, I will do just immunosuppression reduction plus or minus surgery. Monomorphic variant immunosuppression reduction, CD20 positive or negative. If positive, I will give rituximab plus chemotherapy. If CD20 negative, I will give just chemotherapy. Classical Hodgkin lymphoma, immunosuppression reduction, sure, plus or minus chemotherapy and radiotherapy. I will give direct here, immunosuppression reduction, plus chemotherapy, plus or minus radiotherapy. Classical Hodgkin lymphoma, and this all this should be your management with oncology or hematology team. And this classification, this non-destructive polymorphic monomorphic Hodgkin lymphoma, as we mentioned, is non-destructive, sometimes destructive, all other destructive, already as we mentioned before. And the monomorphic beta cell, as we mentioned, beta cell neoplasm or T cell neoplasm, we classified this before. This pathogenesis, as we mentioned, infection from saliva, virus, to naive beta cells in submucosa, to genomic application in the germinal center, and this latent B cells with immunosuppression will end by deactivation and will end by graft dysfunction and end-stage renal disease, as we mentioned here, end-stage disease. Pathogenesis, as we mentioned here, Epstein-Barr virus will be infected, and cells will be this lack of T cell suppression for activation of this naive or latent beta cells, and this will end by lymphoma and proliferation, as we mentioned before, by absence of T cells or immunity or host immunity. This will lead to proliferation and early phase and polyclonal and polyclonal expansion and clonal expansion, early lesion, polymorphic and morphic lesion. As we mentioned before, either the Epstein-Barr virus will come from primary infection or from graft from a donor, and this will be our body or our host defense CD8, CD4 natural killer will keep this beta cells, the main beta cell in latency phase. When the patient receive immunosuppression, this will lead to reactivation of these beta cells and proliferation, and will end this by our post-transplant lymphoproliferative disease. Epstein-Barr virus negative disease, genesis of Epstein-Barr virus negative PTLD is less clear, diagnosis later, and the death will come to pathophysiology, as we mentioned before. I will not take time for that. For diagnosis, PTLD has a wide differential diagnosis. For example, involvement of transplanted kidney may mimic rejection. Sometimes the patient came to emerge or consult post-kidney transplant with rising creatinine single rejection. This is one differential diagnosis. And don't forget viral infection, especially Epstein-Barr virus. You should send Epstein-Barr virus DNA PCR. Will come to that. And isolated CNS disease resemble opportunistic infection, toxoplasma TB fungi, differential diagnosis. For that, for this reason, tissue biopsy is essential. Tissue biopsy, backbone diagnostic tool, the most important diagnostic tool for post-transplant lymphoproliferative disease is tissue biopsy. Tissue biopsy to establish diagnosis, stage and degrade is to establish diagnosis. 100% this PTLD by tissue biopsy. To stage your disease and degrade your disease, Epstein-Barr virus positivity determined by immunohistochemistry, also by tissue biopsy. Expression of the cell surface antigen CD20, another chest X-ray and staging CT, MRI, and PET scan, also bone marrow aspiration, and find this. All this investigation should be done for your lumbar puncture with CSF cytology. If CNS this is suspected, suspect this patient is delirium like that, and you think this patient may be also, you should do lumbar puncture. Routine blood test, including serum, LDH, and other blood tests. Don't forget, tissue biopsy is the most important. EBV positivity with immunohistochemistry with a biopsy, and CD20 also, expression of the cell surface antigen CD20 should be done also by biopsy, chest X-ray, and CT, MRI. There's a PET scan, bone marrow aspiration, lumbar puncture, routine blood test, and routine blood test, and LDH. Diagnosis. Both PTLD diagnosis, history and physical examination, CBC comprehensive chemistry panel, Epstein-Barr virus load by DNA, PCR, plasma, blood, PCR, blood, PCR, okay, for Epstein-Barr virus DNA. The tumor lysis syndrome chemistry and Epstein-Barr virus status of recipient. A single elevated Epstein-Barr virus PCR is less informative. Histological confirmation of tumor. This is the most how to diagnose: history, physical examination, CBC, and another biochemistry, and the Epstein-Barr virus load, and by PCR and blood, and histology by tissue biopsy. As I mentioned, for diagnosis, ABV specific serology, ABV PCR, ABV also CF, DNA also can do so, spinal fluid. And imaging, traditional imaging, whatever you like, and the PET scans, most important. Tissue diagnosis, bone marrow biopsy. All this investigation should be done. Another endoscopy, lumbar puncture, can biopsy from PIT, whatever. This will help diagnosis, and tissue biopsy also to be help your diagnosis. Epstein-Barr virus serology by PCR, and this will discuss before, and this incubation period, acute phase, all and recovery. We discussed this before. Biopsy under excisional biopsy is preferred than aspiration or needle biopsy, not like kidney biopsy. If you find lymph node, just take excisional biopsy preferred, or any mass to be taken out, and histopathology investigated. Details histopathological and immunophenotype evaluation. Epstein-Barr virus ER by immunohistochemistry, molecular and genetic testing also may be required. To mention primary EBV infection, IgM titer are elevated in primary patient like in children, most common in children. Reactivation fourfold IgG titer also maybe from reactivation. Negative EBV virus does not rule out negative Epstein-Barr virus PCR does not rule out the presence of PTLD. Bone marrow aspirate biopsy is appropriate to determine if the marrow is involved in the disease process. Suspicion of CNS neurological involvement, lumbar puncture should be done, CT, MRI, and all this should be done as a screening. The most important intervention for management is decrease in immunosuppression in the hope EBV-specific immunity will be restored or develop. In particular, immunosuppression decrease may allow the expansion of Epstein-Barr virus-specific cytotoxic to lymphocytes. It will be proliferated and reactivated CD8 and CD4 cytotoxic natural killer, able to target and analyze EBV-infected clones. This is the aim of decreasing immunosuppression, to give a chance to activate or enhance the activity of your cytotoxic or host immunity, cytotoxic T cell, CD4, CD8 natural killer, and cytotoxic, all these cytotoxic lymphocytes. This will target and analyze the Epstein-Barr virus infected clones. As I mentioned, immunosuppression is the first step. Stop all anti-proliferative. And the most important, stop all this anti-proliferative, azathioprine and MMF. Then C9 go by 50%. You target your tacrolimus or cyclosporin, either tacrolimus 3 to 5 or staph level, or cyclosporin 50 to 100. That's good. Continue steroid because increase the risk of rejection. Just continue steroid. Consider replacing C9 with sirolimus, maybe also another option. 30 to 50% will respond to immunosuppression alone, decrease immunosuppression, particularly those with diffuse B-cell hyperplasia or polymorphic disease. Response assessed by serial LDH measurement, at least if you don't have facility, just check your LDH, repeat imaging, and if the test is available, especially EBV virus, specific cytotoxic T cell, you can do that. And the same EBV PCR also. Decrease immunosuppression risk. Decrease immunosuppression risk, allograft rejection. Just put this in your mind. Patient should be monitored closely for rejection. Reduce immunosuppression, as I mentioned before, C9 by 50% and discontinue as an MMF, regression PTLD around 20 to 80%. When you do this C9 by 50% and stop azathioprine or MMF, anti-proliferative, this will regress around 20 to 80% of poly or monoclonal disease. For critically ill patient with extensive life-threatening disease, all non-glucocorticoids should be discontinued. Any patient who is sick and critically ill will stop all and they will keep only the steroid. In contrast to that staging lymphoma in an immune-competent patient, restaging in transplant recipient is performed at 2 to 4 weeks. Reduction is the cornerstone of treatment of PTLD. Reduction of immunosuppression is the cornerstone. And around 40% after reduction of immunosuppression will respond to that, to immunosuppression reduction. PTLD related to solid organ transplant, 30 to 40% of the patients have acute rejection. So take in your point, that's I will give you the clinical point only. Take care, when you do a reduction to immunosuppression, around 30 to 40% of the patient will develop acute rejection. Epstein-Barr virus negative disease less responsive to reduction of immunosuppression. This need more aggressive treatment. Patient with Epstein-Barr virus negative disease less responsive to immunosuppression reduction. Bulky disease more than 7 centimeters in diameter and the advanced stage, this will need more than aggressive management by chemotherapy more than reduction of immunosuppression. We mentioned this mechanism of reduction, DC anti-proliferative, MMF azathioprine, and reduce calcineurin inhibitor to half. Consider towards inhibitors, monitor rejection, renal function, and also donor-specific antibodies, monitor lymphoma, EBV virus PCR, may restage in 4 weeks on response. And very good response, especially in early lesions, you will find good response. The treatment here just summarize reduction in immunosuppression, the first step, maybe surgery also, maybe radiotherapy, immunotherapy in future, chemotherapy in patients with beta, Still, PTLD are responsive to rituximab and reduction immunosuppression, you should consider chemotherapy. Should not respond to immunosuppression, the pressure or reduction, and can receive also rituximab and stay resistant. Burkitt's lymphoma need chemotherapy, Hodgkin lymphoma need chemotherapy, peripheral T-cell lymphoma need chemotherapy, primary CNS lymphoma need chemotherapy, other uncommon lymphomas need chemotherapy. Beta cell depletion therapy, rituximab in patient non-destructive PTLD and not response, polymorphic PTLD or not response to immunosuppression. Monomorphic diffuse large beta cell lymphoma like the PTLD not responding to reduction immunosuppression. With rituximab consolidation versus chemotherapy, rituximab allow identification of patients that can be tied to sequential consolidation regimen based on initial response. Indicated in diffuse rituximab indicated in diffuse CD20 disease resistant to reduction immunosuppression, as we mentioned before in the diagram. An added benefit of that rituximab likely over the prophylaxis against rejection is the most important. Serious side effect we know. Exceptional maybe allergic reaction of anaphylactoid reaction. Beware of tumor lysis syndrome. Remission in 50 to 60% of patients, especially in positive Epstein-Barr virus. The mention here is the job of rituximab just to inhibit this proliferation and the activation of T cells. This patient with recipient negative donor positive, the high risk for PTLD ABVR associated. The patient with donor positive, more risk for PTLD disease in comparison by donor and recipient positive or recipient positive donor negative. With all this compares, the most highest risk is donor positive and recipient negative. And we, because immunosuppression, this will give a chance to naive beta cells or latent beta cells with infected Epstein-Barr virus to be reactivated in absence of our immunity. This rituximab come to inhibit this proliferation and activation. Rituximab and the CD20 monoclonal antibodies, first line of treatment after decreased immunosuppression, first line of treatment after decreased immunosuppression, field or no resistance to reduction immunosuppression, the first line after that is rituximab. And side effects include persistent beta cell lymphopenia, persistent beta cell lymphopenia, and hypogammaglobulinemia, tumor lysis syndrome of bulky disease, reactivation of viral infection, especially hepatitis B virus, angioedema, and hypotension as an anaphylactoid reaction. But this is a side effect. Don't forget to put this in your mind now. Persistent beta cell lymphopenia, persistent beta cell lymphopenia. This one, you know, the patient pregnant and with need now to trial and field the CNI and the prednisone and the new trial for rituximab. Put this in your mind. High risk for infection for her baby because persistent beta cell lymphopenia and the hypogammaglobulinemia. This is beta cell lymphopenia and the hypogammaglobulinemia. As a side effect of treating this tumor lysis syndrome, if disease, reactivation of viral infection, you should check hepatitis B virus before any plan for treatment of treatment with rituximab. Anaphylactoid reaction, angioedema, and hypotension. Initial studies response rate 75% for early disease, 45% for late disease, complete remission 26, around 30 to 50%. This initial study response for rituximab, 75% response to early disease, 45% for late disease, complete remission on 30 to 50% of PTLD. In patients with partial remission, second course increase complete response rate to 30 to 60%. 50% relapse rate with rituximab 50% relapse rate with rituximab monotherapy. Rituximab monotherapy, 50% relapse rate. Survival with rituximab here and rituximab here, graft survival, progression-free survival is better than non-rituximab group. Rituximab is better survival as a graft or response to therapy. And that's a summary for rituximab and lymphoma. Rituximab is a chimeric monoclonal antibody specific for CD20 antigen expressed on normal and malignant beta lymphocyte, but not neither T cells, precursor, nor plasma cell. Rituximab induced death of CD20 cells by antibody And the complement-dependent cytotoxicity. The rituximab will induce death of CD20 cells by antibody and complement-dependent cytotoxicity. And by inducing apoptosis, rituximab was developed in the treatment of beta cell lymphoma and has largely replaced other beta cell depletion antibodies, for example, anti-CD21 and anti-CD24, which have been used to treat PTLD also. Okay, and the rituximab is licensed for treatment of advanced diffuse large beta cell lymphoma in combination with CHOP chemotherapy. The dose of rituximab 375 milligram per meter square given with each CHOP cycle. Rituximab is also licensed immunotherapy 375 milligram per meter square for each 4 weeks for 4 weekly doses each month. In patients with early stage lymphoma, rituximab 1, rituximab for aggressive non-Hodgkin lymphoma, NICE technology, April 65 September 203. Cytotoxicity chemotherapy usually observed in CD20, and this cytotoxic chemotherapy CD20 PTLD and the T-cell natural killer cells PTLD, CD20 PTLD, and other. In children, low dose chemotherapy, cyclophosphamide prednisone result in high initial response rate, although event-free survival at 2 years is suboptimal at 58%. Increasing use of rituximab chemotherapy, combination CHOP and sequential therapy. Systemic chemotherapy required in patients with polymorphic chemotherapy. Patients with polymorphic disease will not respond to treatment listed above. All the treatment above. Variably needed in polymorphic disease. Monomorphic disease also needs that. So indicated if decreased immunosuppression not possible because of ongoing acute rejection, you can go to chemotherapy. Most regimen use are anthracycline-based CHOP, cyclophosphamide, doxorubicin, vincristine, prednisone, many other, for example, Zypromag or Cytopom. These other regimen by oncology, significant treatment-related toxicity, especially neutropenic sepsis, beware of tumor lysis syndrome, and remission in 60 to 70% patients with systemic chemotherapy. Surgery and radiotherapy useful in patients with localized disease who do not respond to diffuse immunosuppression. This other line, if the patient not respond to immunosuppression, you can go to surgery and radiotherapy. And this to summarize, current regimen for treatment PTLD, decreased immunosuppression, then rituximab, then chemotherapy, then you can use antiviral therapy also, and high dose therapy of autologous hematopoietic stem cell transplant. And this risk is stratified sequential therapy by rituximab and the chemotherapy. High risk, we need chemotherapy. Low risk, you just continue rituximab, and this should be decided by the oncology team and the hematologist. This is not by nephrology. We need consult for hematology to stage the disease and to decide this patient will go to rituximab with CHOP if CD20 positive, if CD20 CD20 negative, will go to direct to just CHOP therapy. If the patient just will low risk, we can go to rituximab only. This is the protocol of rituximab and the CHOP therapy by oncology hematology. If you would like to read and give a look. And the risk is stratified sequential also by hematology, will decide for that. Antiviral therapy, acyclovir suppress EBV virus replication in vitro by blocking the viral thymidine kinase. This mechanism of acyclovir or acyclovir, the mechanism of blocking or inhibition thymidine kinase. However, Epstein by virus driving tumor do not express on thymidine kinase. There is no rule for antiviral treatment PTLD till now. PTLD. Acyclovir or foscarnet in absence of reduction in immunosuppression is not considered effective treatment. Acyclovir and acyclovir foscarnet not effective if you will not start by immunosuppression reduction. Beta lymphocytes that are latent infected with EBV virus are generally not susceptible to nucleoside type antiviral agent, viral enzymes, antiviral, I think antiviral no rule here. Administration of arginine, butyrate has been shown to increase the expression of some lytic phase genes, including Epstein by virus thymidine kinase in latency infected beta cells. This is the most important cell to clear. Administration or usage of arginine butyrate and plus ganciclovir has been shown render latency infected previously antiviral resistant EBV virus lymphoma cells remain or an investigation about promising new therapy for this just under investigation, and we'll see in future. This patient with antiviral therapies and with no prophylaxis. This was prophylaxis, better survival here. Probability of viral positive and the year of transplant is better with an antiviral prophylaxis. And this patient with rituximab, here a patient with no prophylaxis and this patient with prophylaxis. I think no significant difference, but here patient with rituximab and not no induction. This as induction therapy. This as induction therapy for transplant and this as a prophylaxis. This patient received this antiviral prophylaxis, and this none, no significant difference. This patient affected by rituximab, better transplant survivor and decreased risk of PTLD better than a patient non-rituximab induction. Home message: monoclonal morphic PTLD, CD20 PTLD, rituximab plus combination of chemotherapy. Monomorphic PTLD, you will use rituximab plus this CD20 positive PTLD, rituximab, the main management plus combination of chemotherapy, concurrent or sequentially plus reduction in immunosuppression. This with monomorphic, this is a home message today. If your biopsy report came in your hand, monomorphic PTLD with CD20 positive, I need rituximab for this patient and the chemotherapy plus reduction in immunosuppression. CD20 positive PTLD, no rituximab, combination of chemotherapy plus reduction in immunosuppression. Okay, that's clear. Okay. Classical Hodgkin lymphoma like PTLD, chemotherapy direct with or without radiation therapy. This classical Hodgkin lymphoma needs chemotherapy plus or minus radiation therapy according to protocol used for classical Hodgkin lymphoma. Surgery is reserved for patients with complications such as perforation or obstruction. Surgery is reserved for patients with complications such as perforation and or obstruction. CNS involvement of PTLD prognosis remains poor even with aggressive therapy. Intrathecal methotrexate is considered many systemic chemotherapy agent. Monoclonal antibody done. Monoclonal antibodies like rituximab does not cross the blood-brain barrier. Small series have described it as rituximab administered to treat isolated CNS PTLD, but not clear. Intrathecal methotrexate is best here. Interferon alpha inhibit outgrowth of this ABV virus transformation beta cell and decrease the oropharyngeal shedding of ABV virus. Inhibit T helper cell which release the cytokines like that promote beta cell proliferation. This is a mechanism, but no proven data for using. I didn't see anyone use that. Just inhibit outgrowth and inhibit T cell helper also. What is the future strategy treatment for? And just to give a look, I put in your mind this beta cell tyrosine kinase or thymidine kinase inhibition or inhibition B13K and emitters, bortezomib also, and this checkpoints inhibitors in future, and anti-CD30 like brentuximab, this also in future. This is a future also under investigation, and we'll see this thymidine kinase inhibitor and bortezomib can be used, checkpoint inhibitor nivolumab, and then CD30 therapy brentuximab also this future management for this, and we'll wait for this adaptive to cell therapy also future waiting for that also. How to prevent? Prevention in 2012, how to prevent? EBV status post donor and the recipient. You should don't try as possible to be EBV match as possible. Don't give any B positive donor to negative recipient as possible. You can give positive to positive or negative donor to positive recipient, that's okay, or negative donor to negative recipient, that's okay. Minimize the immunosuppression as you can, especially the induction with thymoglobulin and high doses immunosuppression. And they start your prophylaxis also to prevent from the start, especially patient donor positive to recipient negative or donor positive to recipient positive with ATG induction. Please give prophylaxis for that patient. We can administer IVIG to maintain high titer of anti-Epstein virus antibody, administer IVIG as a prophylaxis, antiviral as a prophylaxis, reduce the immunosuppression also as a prophylaxis. decrease the ABV mismatch as a prophylaxis or prevention. Planning and monitoring antiviral as a prophylaxis, IVIG, viral monitoring, rituximab, adaptive T-cell therapy, and future therapy. We'll see outcome of PTLD patient has greatly improved when used adjuvant to new lymphoma-specific protocols, as well as this better supportive care with new protocols for management of PTLD. 70% of a PTLD patient has achieved complete remission with median survival approximately 6 to 6.6 years. 70%, around 70% of our PTLD patient achieved complete remission with median survival more than around 6 years. Ranging from beta cell lymphoma, immunoblastic lymphoma, 1 year mortality in CTS registers was 40 to 50%. This 1 year mortality, 40 to 50%. And this depends on the late of the disease, older age, elevated LDH, and T-cell, PTLD. All this have prognosis, CNS, multi-system disease, monoclonal disease, Epstein-Barr virus. All this will increase the 1 year mortality by this disease. Early prognosis, early PTLD better than survival, cumulative survival better than late PTLD. Single site PTLD better survival than multiple site PTLD. Graft PTLD better survival than cumulative survival other than location of PTLD. Hepatitis negative better than in survival than hepatitis positive PTLD. Prognosis, age less than 50, early or promorphic disease, EBV virus, Epstein-Barr virus disease positive, low LDH with treatment or decreased immunosuppression, decreasing in LDH. This is about prognostic signs. Poor prognosis, age more than 50, monomorphic disease, Epstein-Barr virus negative. This is poor prognosis. Persistence elevated for LDH. This is poor prognosis. Outcome, more than 80% of patients with early polymorphic disease enter remission with decreased immunosuppression, relapses uncommon, 10% of graft loss due to rejection. Just 10%. 80% with early or polymorphic disease and with decreased immunosuppression. 80% remission. Relapse uncommon, just 10% graft loss and rejection. In patients with polymorphic disease resistance to decreased immunosuppression or monomorphic disease treated with rituximab plus or minus chemotherapy, 50 to 70% enter remission with the treatment. Relapse is common, 30 to 80%. 5-year survival around 30 to 70%. This to equally to PTLD and chemotherapy toxicity also. Transplant previously treated PTLD is not an absolute contraindication to further transplant. The patient should be in sustained remission for 5 years. It's likely at least 5 years sustained remission to be retransplanted, okay, but not absolute contraindication. It's likely that EBV specific immunity will have developed, measure EBV, Epstein-Barr virus, IgG, and EBV cytotoxic T-cell also. If possible, monitor a patient closely following the retransplant. In summary, PTLD is a vertical complication following kidney transplant. Epstein-Barr virus infection is an important risk factor for PTLD development. Even so, 40% of the cases are EBV negative in modern series. The overall level of immunosuppression seems to be an important driver for increased risk of PTLD in kidney transplant recipient. All the lymphocyte-targeting monoclonal antibodies and the tacrolimus have been specifically identified to increase the PTLD risk in some studies. Risk of immunosuppression is commonly accepted on the first step in reduction, and immunosuppression is commonly accepted as first step in prevention and treatment of PTLD reduction. Immunosuppression. In recent decades, outcome in patients with PTLD have improved because of introduction of more uniform treatment protocol, improve supportive care, and increase awareness and use of and CT scan in staging and response monitoring. Several novel therapeutic agents are currently being evaluated in management PTLD. Finally, repeat transplant appears to be an option after prolonged complete remission. Repeated transplant after prolonged complete remission. Epstein-Barr virus PTLD continue to be potentially life-threatening complication of solid organ transplant. A pathogenesis of PTLD related to outgrowth of Epstein-Barr virus positive T-cell proliferation in the setting of chronic T-cell immunosuppression. Epstein-Barr virus negative tumors and T-cell tumors can also occur. Primary Epstein-Barr virus infection, donor positive and the recipient negative, is the most important risk factor for early PTLD. Late onset of PTLD is increasing seen and carries poor prognosis. Late onset carry poor prognosis, as we saw before, in comparison by early and late. High index of suspicion, and the biopsy remains a cornerstone of diagnosis. High index of suspicion and the biopsy remain the cornerstone of diagnosis. Rituximab has improved the outcome. Recent years prognosis has not changed. The prevention largely relies upon limiting the patient exposure to aggressive immunosuppression regime, aggressive withdrawal, and tapering of agent required for graft acceptance and antiviral prophylaxis. Implementation of screening and intervention in high-risk individuals appear to have lowered the incidence of early PTLD. Immunosuppression reduction is a cornerstone of therapy. Early lesion, for most of the patients with early lesion, we suggest reduction of immunosuppression alone rather than in combination with other therapies. Other agents are generally reserved for those patients with residual disease despite reduction in immunosuppression, or for those who cannot tolerate reduction in immunosuppression. Polymorphic PTLDs, for the most patients with polymorphic PTLDs that express CD20 positive PTLD, CD20 positive PTLD, we suggest the use of rituximab in addition to reduction of immunosuppression as tolerated rather than reduction of immunosuppression alone, or this combination with chemotherapy. I think this point is clear for each one now. Again, reduction in immunosuppression is a cornerstone in management of PTLD. Rituximab is indicated in non-destructive PTLD, polymorphic PTLD, and monomorphic diffuse large beta cell lymphoma like PTLD not responding to reduction in immunosuppression. Chemotherapy is indicated for Burkitt lymphoma, Hodgkin lymphoma, peripheral T-cell lymphoma, primary CNS lymphoma, and beta cell PTLD are responsive to immunosuppression. Don't forget this diagram. PTLD early lesion, immunosuppression reduction, plus or minus surgery. This for early lesion only. Polymorphic variant, immunosuppression reduction. If CD20 positive, I will give rituximab plus or minus surgery. If negative for CD20, plus or minus surgery with immunosuppression reduction, but no need for rituximab if CD20 negative. A monomorphic variant, immunosuppression reduction. If CD20 positive, I will give rituximab with chemotherapy. If negative, I will give just only chemotherapy. Classical Hodgkin lymphoma, immunosuppression reduction plus chemotherapy. Immunosuppression reduction plus chemotherapy in classical Hodgkin lymphoma, plus or minus radiotherapy. These two summarize post-transplant lymphoproliferative disease, early lesion, polymorphic lesion, monomorphic lesion, Hodgkin lymphoma, how to manage, and this management responsibility of oncology by help of transplant. For high-risk patient after solid organ transplant, hematopoietic stem cell transplant, for follow-up monitor Epstein-Barr virus blood or plasma PCR to monitor Epstein-Barr virus DNA. Elevated level, very high risk, consider rituximab. Progression like that, donor T cell like that, with hematopoietic stem cell transplant can go to chemotherapy, and we'll see if patient level not high risk, just monitor our level not high, just monitor frequently and reduce immunosuppression if possible. Elevated Epstein-Barr virus DNA with no other sign or symptom, just continue to monitor. If sign or symptoms will be individual, do imaging and biopsy. We'll do all imaging for staging and biopsy if possible. Localized disease we can do by surgery and decrease the immunosuppression. Early disease, just reduce the immunosuppression. High-grade extensive disease will go to rituximab. If no response, will go to chemotherapy. Just all of this also for your monitoring. I think I try to clarify this topic in kidney transplant. I have all topics, but this is most of when I will find an interesting case, I will present for you at the moment. Don't worry. I'm trying to presenting the actual case, clinical case I find, and I try to simplify the topic for you as I can. I hope you get benefit from this topic. And this is our reference for anyone like to read any more information. والحمد لله وشكر لله ونسألكم دائما الصلاة والسلام على حبيبنا ومحمد صلى الله عليه وسلم، والسلام عليكم ورحمة الله وبركاته، ونلقاكم في فيديو قادم قريبا بإذن الله، ونسألكم الدعاء بالتوفيق والسداد والبركة في الوقت والمال والأهل والأولاد والصحة والعافية، ونلقاكم قريبا بفيديو قريب في الكدني ترانسبلانت in next days. Thank you so much. السلام عليكم ورحمة الله وبركاته، ونترككم في رعاية الله وحفظه. السلام عليكم ورحمة الله.